Okay, so this is the first case. There are a total of 2 questions in this case, so watch out for them, and when they come, then you can use your Mentimeter to join in. So this is a 17-year-old MSM living with HIV who we've been looking after at our center at Chulalongkorn University. He was actually using PrEP with us for a year prior to his infection, and during this time had poor adherence and had HIV testing every 3 months as per standard protocol in our country, had a past history of anal warts. And during the time that he was diagnosed, it was actually the peak of the COVID epidemic, and so we actually had sent him a self-test at home. You're probably wondering why he had a self-test done. And this was consequently confirmed, so he came in person to confirm that he had HIV infection and was started on ART. The regimen we used was 3TC, abacavir, and dolutegravir. At that point, he was 17 years old. CD4 count was on the low side of 235, and testing for hepatitis B, C, and syphilis was negative at that point. And after starting ART, he continued to have poor adherence. His past history was that he'd been sexually active for 2 years and had 20 lifetime sexual partners. His social history was quite sad. He had gone through a situation in his house with parental divorce, had run away from home, was living in a homeless shelter at that point, and had a 31-year-old partner who was working at a bar. He had not disclosed his diagnosis to his partner, and he was also working at the same bar at night. 10 months after ART initiation, he was continuing to have poor ART adherence, and we followed up his laboratory tests. Thankfully, his CD4 had started to come up, but viral load, as expected with his poor adherence, was high at over 600,000, and RPR was reactive. His last test was 6 months ago, which was non-reactive, and the patient was asymptomatic, so we presumed the patient had early latent syphilis and was treated for that. 2 years into ART initiating, he actually was lost to follow-up, but one of his friends at the homeless shelter happened to also be living with HIV and came in for follow-up, so he accompanied his friend, and so we asked him to get testing when he was at our clinic, and he said to us that he'd unintentionally lost 5 kilograms in the previous 3 months, and said he was continuing to use intravenous drugs still, was drinking quite heavily, was still on the same regimen officially, but wasn't taking it very much. Physical examination was unremarkable at that point. And our laboratory workup showed that he had a mild transamnitis, and hepatitis HBs antigen was positive, and the viral load was over 20,000. And we also did a hepatitis C screening point of care test, which was positive, confirmed with an HCV RNA. And the viral load was 69,000. RPR had come down. So this is the first question, so get your phones ready. Which infection would you treat first? So we have this 17-year-old MSM living with HIV, transamnitis, hepatitis B and C infections. Which one would you treat first?
So get your voting.
Oh, I think they need to see the options first. I think that may not.
It's there at the bottom.
Oh, it's on the bottom. Okay. So choice 1 is, would you treat the hepatitis B first? Choice 2, hepatitis C. Choice 3, not sure, need more information. And the last choice is, which seems to be the most popular, can be treated at the same time.
So maybe while we're getting everyone's opinion, do you want to just, as an expert panel, do you want to comment? Claire, you want to go first?
Sure. This unfortunate boy, so a known boy with young man with HIV, and has acquired 2 viruses, hepatitis B and hepatitis C. Well, look, hep C is probably the easiest to treat. We all know that it can be treated fully cured in 8 weeks or 12 weeks, which is great. So I think the more urgent ones to treat, the more urgent one would be the hepatitis B. I think it's also recognized that when you're treating for hepatitis C and co-infection, it can reactivate hepatitis B or make it worse. So I would be treating hepatitis B first, and the advantage is you can treat that together with HIV as long as you use 2 drugs active against Hep B.
So again, it's a complicated situation,
Yes.
and you go through some. So most people said both could be tested, treated at the same time, and then the next one was HPV, HPC, and then need more information. Can you take us through?
Yes. Do I just press forward?
Yeah.
Oh.
Excellent.
Something's supposed to happen.
Yeah.
Okay. Right. So we suggest you treat hepatitis B first for the reason that Professor North just mentioned. So we know that HBV reactivation has been observed in people with co-infections with HBV and HCV. If you treat the HCV first with acting antivirals or DAAs. So before initiating HCV therapy, it's suggested in the guidelines that somebody who has HBs antigen positive should receive ART that includes 2 agents with anti-HBV activity. So this could be TAF or TDF plus 3TC or FTC, depending on what's available to you. And the duration of HBV treatment before HCV treatment isn't clearly stated in the guidelines, but we suggest approximately 3 to 6 months or until HBV viral load is suppressed. Any comments?
Comment?
I've just got a question maybe. In our setting in South Africa, an older adolescent would start actually on TLD. So I was just wondering why he started on the back of a containing regimen.
That's a really good point. And abacavir is also one of the first-line agents, so no other reason than that. But we also now have TLD available.
So maybe just to add to the question, is really around, when you're not using tenofovir and 3TC as a dual regimen, the difficulty is there that you're treating with a single agent. So in a non-TLD based regimen, I think the difficulty is around trying to see whether you need to maintain and both treat the hepatitis B and the HIV as separate entities and make sure that your regimen completely covers both.
Yeah, I think that's a very good point, is to make sure you have at least 2 active agents. Yeah. And I'll say no more because that would be answering the next question. So the next question is, get your mobile phones ready. What would your treatment regimen be for both the hepatitis B and the hepatitis C? And just for your information, I've put the generic prices and the drugs that are available in Thailand. You might be wondering, I'm reliably told that in Queensland you also have access to GP that is available, but I've only put regimens that are available to us in Thailand, which is why you have the choices on the screen. Oh. I think there were three choices, right?
Yeah.
I don't know why there were 6.
I think just take people to the answers.
Sorry.
Take them to the answers.
Okay, so
Yeah.
okay, so we suggest, as Mo mentions, that an ideal regimen to use is a regimen with at least 2 active drugs, so TDF and 3TC and dolutegravir and sofosbuvir and velpatasvir. I'm sorry about the pronunciation. And I'll just take you through the reasons why. Before we go into the details of that, I just want to remind you of what we would typically expect once you start treatment, when we would expect people to reach viral suppression, which would then guide you as to when you would start your next regimen or when you would expect to bring the patient in for follow-up to check on their blood results. And so we know that for dolutegravir-based regimens for HIV, the typical time to viral suppression is 4 to 12 weeks. It's much longer for hepatitis B virus with TDF-TAF plus 3TC or FTC, which is typically about 12 to 24 weeks. And for HCV with acting antivirals takes about 8 to 12 weeks. So like I mentioned previously, we would suggest the patient is on TAF or TDF plus 3TC plus FTC. And also it emphasized in the guidelines that this should be based on a fully suppressive ARV regimen. And an alternative that could be used is entecavir, but the guidelines suggest that this must be on a suppressive ARV regimen, because if the patient is not on one, it risks the selection of the M184 mutation. And also that if you decide that the patient needs to change the ART regimen for whatever reason, that the anti-HBV medications should be continued. And if they need to discontinue their ART medication, there's a risk of hepatocellular damage from HBV reactivation into monitor. The graph that you see on the right of the screen, I'm sorry it's a bit small, but I really just wanted to use this to point out that in this fantastic paper that goes through HIV, HBV, and HCV co-infections, that we would suspect infections as such in people who have risk factors, which is really well reflected in the case that we've used in this. So, can I use a pointer? Oh, it doesn't work. Okay, so if you look up on top of the screen, the risk factors for HIV, HBV, and HCV co-infection are present in our case study as well. So somebody who is an MSM, and the consequences, of course, which we're looking for is chronic hepatitis. And just to point to the bottom of the screen, that people with co-infections have a higher risk of disease progression, have increased rates of severe liver fibrosis and cirrhosis, and an overall rate of approximately 5% progression to hepatocellular carcinoma. So just to be aware of this.
So maybe just a question to the panel. I think one of the difficulties in this patient is really around adherence. I mean, now we've got 3 diseases that we have to treat, and he hasn't really been, adherent to his antiretroviral treatment as well. So one of the questions would be, how would we try to engage this adolescent and ensure that we get them to be successfully navigate all of these different treatments that we think that they should be taking? So it's a general question.
No, I'm not going to answer that easy one.
Yeah, I think this case is very difficult because he have poor compliance at the first time, right? So yeah, may have to talk with him about the reason why he have to get all of the medications. And for me, I will talk with him whether or not if he don't take the medication may have the disease progression or the adverse outcome or the complications of the liver, and try to engage him into the treatment.
Yeah, I think one of the difficulties we often face is really around how do we frame these questions, and we often left with framing it in a negative context of it being doom and gloom if you don't take your treatment. And sometimes I do often find that it's always better to frame it in a positive light. And again, I think one of the good things here is one, the hepatitis C treatment is for a shorter duration of therapy, and that we will stop it. So there's some light at the end of the tunnel that this is a shorter course of treatment that can be stopped after a while. And the hepatitis B treatment is combined with the antiretroviral treatment. So it is working in combination with each other. So I think, again, in addition to the additional tools, is really around framing it a way that does highlight the positives and also future outlook in terms of the treatment regimen that you're going to use.
Mo, can I just say I totally agree. And one of the great joys for me now in HIV medicine is when I meet a new adolescent or child with HIV, I can tell them that, the outlook is fantastic. They have a normal lifespan, they can become parents, grandparents, lead a normal life. They don't even have to tell partners they have HIV if they, are undetectable, suppressed. So you're absolutely right. I agree with the positive framing.
Great, let's continue with the case. I've kind of not completely answered the question yet, but I am getting to it. But just before we go on to the guidelines of what is recommended for treatment, I just wanted to go through the basics of the available drugs for hepatitis C, which can be divided into those that act against the structural proteins and the non-structural proteins. And so I understand that glecaprevir is available in Queensland, which is one of the NS3-4A protease inhibitors, and they're usually combined with a drug from another class. And so from the drugs that affect the non-structural proteins, there are the NS5A inhibitors, such as ledaspasvir or velpatasvir, which we saw in our case study just now, and also the NS5B polymerase inhibitors, such as sofosbuvir. So these are, if you haven't seen these already, the treatment guidelines issued by the WHO in 2022, and I think they're very useful and practical. So they suggest once you have screened somebody positive for HCV to confirm the diagnosis with an HCV RNA, and then look at whether the patient has any evidence of fibrosis. And then depending on their age, and for children and adolescents, anybody age 3 and over can actually be treated with these medications. You can give a combination of sofosbuvir, velpatasvir, which is what this patient received for 12 weeks. I understand in Queensland you have glecaprevir and pibrentasvir, which can be given for 8 weeks, which we didn't give this patient, even though the duration is only 8 weeks shorter because it's not available to us. And an important point to make also is that you need to remember to assess the cure. So once the course is completed, 12 weeks after the completion, we'll look for sustained virological response, or SVR, at 12 weeks. So just a reminder that the WHO 2022 priority guidelines are the use of DAA treatments for adolescents and children over 3 years of age to try and simplify services delivery, decentralization. So this is on the same themes as what we talked about this afternoon on TB, and also to try, where possible, to use point-of-care testing to support your service delivery models. And I just wanted to point out that one of my colleagues, Kristen, who's sitting here, will be presenting some further information on hepatitis C in Thailand in this afternoon's poster walk, if you're interested. A quick note about antiviral medications for hepatitis B and C and drug interactions, of which there are many. To be careful of this when you're treating patients, and also to remember, if your patient is not immune for hepatitis A and B, to give them vaccinations, talk to them about maybe cutting back on the alcohol and what can be done to prevent transmission. And there are many, many drug interactions, which you can see this website for further details, done by a fantastic website by the University of Liverpool. But some of the major interactions are with TAF and TDS and protease inhibitors, or TAF and pentamidine, and also a few other drug interactions with lenacapavir protease inhibitors and efavirenz, and you can see further details at the website. So what about outcomes? What happens after we treat these adolescents? What do we need to be looking for? So then we know that the natural history of HCV and HIV co-infections are such that there are lower rates of spontaneous HCV clearance in these patients. As we mentioned earlier, they are more at risk to have rapid liver disease progression, and there's impaired recovery of CD4 cell count even following effective antiviral therapy, and there's accelerated progression to cirrhosis decompensation and HCC, and there are also higher rates of HCC at a younger age. So in short, to remember to be aware of this and to follow up your patients. And in terms of treatment responses, you might be wondering, well, I've never used this medication before, what happens after this? And the information we have so far is that over 95% of SVR12 in all age groups between 3 and 17 has been seen. And so it's quite encouraging. And this is regardless of what regimen you use. And so whatever is available to you, we would encourage you to try and treat hepatitis C when you assess that it's safe to do so. And another one of my colleagues is talking at IAS about hepatitis C, which I'd invite you to go and see if you're interested. And so in summary, this was a 17-year-old MSM living with HIV who we later on discovered had HBV and HCV co-infection, had poor drug adherence, and a history of intravenous drug use. I want to point out that in the end, this patient, because of his poor drug adherence, did not, we did change him to TLD in the end, but he was not started on hepatitis C treatment because of his poor adherence, and we haven't even been able to get him in for assessment of cirrhosis yet. So that's where we are with this case. And the key points to take home with this case are that an HIV, HBV, and HCV co-infection to treat the HIV and HBV first, and there are DAA agents available for HCV management in over 3-year-olds. It takes only 8 to 12 weeks. Beware of drug interactions, and remember to try and make testing accessible for your patients so that they can get into treatment. Thanks for your attention.